Hi, and welcome to the ToxFox, a central hub for all things toxicology. My name's Anastasia, and I'm an emergency medicine resident in California. I recently went to Sonoma, to wine country, so I thought it would be fitting to talk about the toxic alcohols. Ethylene glycol, which is found in antifreeze, isopropyl alcohol, which is found in hand sanitizer, and methanol, which is found in moonshine, as well as window washer solution. But before we get to business, here are some photos of me going to Sonoma. You have a 75-year-old gentleman who's brought in by EMS. He was found next to an empty bottle of window washer solution. His GCS is 7, so you intubate him. He is afebrile, normotensive, not tachycardic, and without any signs of trauma. You get some basic labs. You notice right away that his bicarb is low and his creatinine is elevated. His serum osms are 380. His CT head does not show any kind of brain bleed. His VBG suggests a metabolic acidosis. His alcohol level is 0, his beta-hydroxybutyrate is less than 1, suggesting that he's not in alcohol ketoacidosis, and his aspirin level is undetectable. You decide to draw a volatile panel, and then you remember that one class in medical school where you talked about anion gaps and osmolar gaps, and obviously you figured that as a doctor, you definitely would not need to do any of those formulas for yourself because the computer would do it for you. Oh, you are so wrong. You definitely need those formulas for the boards. So while your patient is quasi-stable, you decide to consult Dr. Google. Anion gap is simply your cations minus your anions. It's going to be your sodium minus your chloride minus your bicarb. Anything less than 12 is normal. In our patient scenario, the anion gap would be 145 minus 110 minus 8. That's greater than 12, so you have an anion gap metabolic acidosis. Osmolar gap is simply your serum osmolality minus your serum osmolarity. It's considered to be elevated if it's greater than 10. Serum osmolarity is calculated by the formula 2 times your sodium plus glucose over 18 plus BUN over 2.8 plus ethanol divided by 4.6. In our patient scenario, the osmolar gap would be 380 minus parentheses 2 times 145 plus 80 over 18 plus 10 over 2.8 plus 0 over 4.6. That's 82 and much larger than 10, so you definitely have an osmolar gap as well. The lab calls you and tells you that your methanol level comes back as 100 milligrams per deciliter. Eek, that's super high. How do we treat this type of overdose? In order to understand methanol overdose treatment, you truly need to understand how alcohol is metabolized in general. Ethanol is metabolized with the enzyme called alcohol dehydrogenase into acetic acid. Acetic acid ultimately becomes carbon dioxide and water. Alcohol dehydrogenase is a super cool enzyme because it can actually metabolize all sorts of alcohols. When it metabolizes methanol, it forms formaldehyde, which ultimately becomes formic acid. Formic acid is the acid that contributes to the anion gap metabolic acidosis that you see in this type of overdose. Formic acid also is toxic to mitochondria and prevents ATP production. One of the reasons why methanol overdose patients describe snowstorm blurry vision is because Mueller cells in the retina are some of the few cells in the eye that actually express alcohol dehydrogenase. With enough formic acid, these cells start to die and cause the visual disturbances. In order to save your patient, you ultimately have to inhibit alcohol dehydrogenase and prevent the metabolites from forming altogether. The compound that does that is famepizole. The loading dose is 15 mg per kg, followed by 10 mg per kg every 12 hours for a total of 4 doses. You can continue with subsequent dosing at 15 mg per kg. If you're in a resource-poor setting and don't have access to famepizole, you can always consider just giving straight liquor such as vodka. Alcohol dehydrogenase has a higher affinity for ethanol than it does for the toxic alcohols, so it will preferentially form carbon dioxide and water if you have enough ethanol around. You want to aim for serum plasma concentration of 100 to 150 milligrams per deciliter of ethanol. Other treatments to consider include bicarb and folic acid. Bicarb will help with the metabolic acidosis, but it will also keep the formic acid in an ionized state and prevent it from crossing the blood-brain barrier. Folic acid will help the formic acid become carbon dioxide and water. One of the treatments you want to consider early on is dialysis. Methanol has a very long half-life, so if you were giving fameprazole, you would actually have to redose it multiple times before all of the methanol gets eliminated. This is very costly and very inefficient, so you want to loop in your nephrologist pretty early. In our patient scenario, you give dialysis, bicarb, and folic acid. Your patient gets better and is ultimately extubated with only minor visual disturbances. Good job, you saved a life. You have a 17-year-old female who's brought in by her friends from a party. They admit to mixing Gatorade with antifreeze because they couldn't buy any kind of alcohol from the store. She's a little bit altered but still talking to you, hypertensive, tachycardic, but otherwise looks pretty darn good. You get some basic blood work and you realize that her labs look very similar to the methanol overdose case we just had. The main difference here is that the creatinine is much higher. You have an anion gap metabolic acidosis and you have an osmolar gap once again. Ethylene glycol gets metabolized by alcohol dehydrogenase into glycolic acid. Glycolic acid is the main acid that contributes to the anion gap metabolic acidosis that you see. Glycolic acid gets metabolized to glyoxylic acid, and glyoxylic acid gets metabolized to several non-toxic metabolites using cofactors such as pyridoxine as well as thymine. But it can also form oxalic acid, which when combined with calcium can cause crystals in your kidneys. Again, the treatment is going to be fameprazole, but you also want to give those cofactors pyridoxine and thymine. You can also consider dialysis. So now that I've convinced you that toxic alcohols cause an anion gap metabolic acidosis and an osmolar gap, I just want to pause. This is great if you're just reading a book. However, in real life, you might actually see something a little bit different. Toxic alcohols contribute to osmolar gap. However, their metabolites, the acids, do not. So if you have somebody who presents very early post-ingestion, they'll have an osmolar gap, but they might not yet have an anion gap metabolic acidosis. Likewise, if you have somebody who presents very late in the course, they'll have a very high anion gap metabolic acidosis, but they may no longer have an osmolar gap. Isopropyl alcohol. You don't really need a complicated case in order to understand this one. Isopropyl alcohol gets metabolized by alcohol dehydrogenase to form acetone. Acetone is a ketone and not an acid. As a result, you'll see ketosis, but you won't see acidosis. You'll obviously get an osmolar gap still because you still are dealing with a toxic alcohol. Isopropyl alcohol can cause GI bleeding as well as rhabdo, so keep an eye out for those. You don't want to give fameprazole in this case because it'll just prolong the intoxication. The treatment here is just going to be time and IV fluids. Let's recap because we just covered a lot of ground. There are three main toxic alcohols that you need to remember: ethylene glycol, methanol, and isopropyl alcohol. All of these will contribute to an osmolar gap, but only ethylene glycol and methanol will have an anion gap metabolic acidosis. Isopropyl alcohol will cause ketosis, but no acidosis. Treatment is going to be fameprazole, except in the case for isopropyl alcohol where it's just going to be time and IV fluids. Methanol patients will describe snowstorm blurry vision, while ethylene glycol patients will have crystals in their kidneys. Thanks for watching the ToxFox, and see you next time.